now we have the last talk in the symposium. I want to tell you something about steps to go to single subject analysis, or to support single subjects with meta-analysis. So firstly, I want to introduce the most important point in clinic. The most important point in clinic is not statistics, it's not high number of subjects, it's this patient, the single patient. That's why I want to introduce a single patient for you. Then I want to discuss how we can increase evidence with meta-analysis. I mean, this is a point already discussed also in the other talks or addressed. Then I want to show you how we can develop concepts with meta-analysis. And the last point is how we can translate meta-analysis into clinical routine. So the first point is the individual patient in clinical settings. So this is, the example is a 51-year-old male real estate lawyer. He is at work and he spends most of the day at working, shuffling papers, reading magazines, or downloading pornography. Instead of working, he also embezzles money at work. When asked about his future, he is very optimistic, making lots of money, what real estate lawyers normally do, I would say, especially also in Germany. He loses interest in his wife and children. He watches TV instead of speaking and develops a strong desire for potato chips. And finally, his manners deteriorate. He eats with hands, stuffs his mouth. So we have deep changes in personality and behavior in this patient. By the way, the picture is not, of course, not the patient, but it's Friedrich Nietzsche from Leipzig, who was born nearby and also buried nearby Leipzig, the philosopher. And he was also discussed to suffer from frontotemporal dementia. The disease is so-called behavioral variant frontotemporal dementia. And as I have shown you, the typical symptoms are disinhibition, apathy, loss of sympathy or empathy, hyperorality, and also changes in eating behaviors. In diet and neuropsychologically, this disease is characterized by executive deficits and also by social cognition deficits. So we have now in the new classification systems, these are the international diagnostic criteria for BV-FTD, we have for neurodegenerative diseases several steps or stages. Possible is the clinical criteria are fulfilled, and probable means that imaging criteria support the disease diagnosis. In this case, there is frontal and anteriotemporal changes discussed to be specific for the disease. So how we can increase evidence with these meta-analyses? As already discussed, we have a lot of papers published. You see here in light blue, brain functional MRI studies published on Medline, and in dark blue, the dementia MRI studies. So we have a lot exponential increase, and we can use these great tools which are available even online and in the literature. So we can go, by going this way with the meta-analysis, we can go from case reports to group studies, to multicentric studies, to meta-analyses, and increase, of course, statistical power. We can generate generalizability. So now I want to discuss how we can develop concepts with meta-analysis. This is now focused on behavioral variant frontotemporal dementia, what I have shown you before, the patient. These are the results of our first meta-analysis. I think it was the first also which used anatomical estimate meta-analysis. And you can see here in the frontomedian cortex and in the anterior insula, there are the hot spots of the disease. So it's not the temporal region, how it was described in the diagnostic criteria, but the frontal areas which are mainly involved. And if we discuss the disease, whether the pattern, the imaging pattern is specific for the disease, we have to, of course, to compare it with other neurodegenerative diseases. And as you can see here, it is specific, so there is no overlap with the regions for Alzheimer's or primary progressive aphasia. These are other kinds of frontotemporal lobar degeneration beside BV-FTD. Why is the disease so interesting? I mean, first of all, it's people suffer from this disease, so the patients are not aware of the symptoms, and the relatives and spouses suffer a lot from this disease. So, of course, it's interesting to understand the disease and to treat the disease. But it's also a very interesting disease because regions are affected which make us human. So, especially the frontal lobe, which increased its relative size across evolution. And one important point in the disease are von Economo-neurons. These von Economo-neurons are located mainly in the ACC and also in the anterior insula, and they are discussed to be related to socio-emotional functions and are found in apes, humans, whales, so in organisms which are highly developed. In behavioral variant frontotemporal dementia, we see a specific decrease in the density of these neurons in these areas. So this is a nice coincidence between histopathological data and the imaging data, what we obtained in the patients. However, I have discussed that we have a lot of publications on dementia and MRI, but we have a lot of brain functional MRI studies in healthy subjects. And the next point I want to discuss is how we can combine these data sets. So we can combine imaging data from disease with imaging data from healthy subjects. Here we have conducted a rather complicated meta-analysis. So in the first step, we wanted to identify the neurocorrelates of the disease, again, now separately for MRI, reflecting atrophy, structural MRI, and FDG PET, reflecting changes in glucose metabolism. And as you can see here, in red, you see the atrophic regions. It's again focused on the frontomedian cortex, anterior insula, and additionally the basal ganglia. And in blue, you can see changes in metabolism, in glucose metabolism, so these are hypometabolic areas. So we can validate the imaging diagnostic criteria and focus these to the frontal region. In the next step, we wanted to extract behavioral correlates. So for this purpose, we went to the probabilistic functional brain atlas of the brain map database. This atlas contained, to this date, 40,000 subjects, healthy subjects, and now 100,000, I think. And these are healthy subjects. So in this database, there were functional imaging studies of healthy subjects. And these are categorized according to several cognitive domains. And we calculated so-called behavioral domain profiles. Here we used the regions identified in the first analysis, where we identified the neurocorrelates of BV-FTD, and we looked whether in these regions we have higher numbers and activations in healthy subjects for specific cognitive domains. So we extracted the behavioral, psychological, or mental correlates of networks involved in BV-FTD. This database contains 5 cognitive dimensions and 83 paradigm classes. So this is a data-driven approach because we use another cohort, a healthy cohort with functional imaging data to extract the cognitive deficits in BV-FTD. These are the results. In blue, you can see FDG PET areas, and on the other side, on the right side in red, you see MRI regions, so which show atrophy. I just want to focus on 2 regions. Here, for instance, for the inferior frontal junction area, which is particularly involved, as known from the literature, with executive dysfunction, cognition was a significant finding for the functional study, which makes sense, of course, in this cohort of BV-FTD. And for atrophic areas, I just want to discuss this area, frontomedian cortex. There we had a lot of emotion, perception, and action. So this region is especially related to these functions. Additionally, we found other cognitive functions which are related to this network. So this was emotion processing, 5 clusters, reward, 5 clusters, cognition inhibition, 2 clusters, and pain processing. So we know also that these patients have a change in pain processing. They have a decrease in pain, actually. What is the limitation in this database in the BrainMap.org that, like in all other meta-analytic databases, you have a predefinition of the categories, so have a predefinition of which tasks are involved. And some tasks are not involved and are not reflected in the database, and so also empathy and theory of mind was to this date not reflected in the database, and that's why we have in a third step, we have combined the imaging meta-analysis where we identified the neurocorrelates of BV-FTD, here again shown in blue and in red, with the neurocorrelates in healthy subjects for empathy and theory of mind. And as you can see here in the yellow conjunction focus or region, you see that the frontomedian cortex seems to be a very important area where these functions interact with atrophy or changes in metabolism. And for theory of mind here in white as well, in the frontomedian cortex, there is an overlap so that these meta-analyses indicate that the frontomedian cortex is a hot structure in BV-FTD that is involved. Another interesting point is that BV-FTD persons might show changes in behavior which are related to moral cognition. That's why it was of interest also to look and to do a conjunction analysis for moral cognition, as shown here in, it's not really yellow, it's rather green. So moral cognition, and these are the networks which are involved in moral cognition in healthy subjects. Here again you see the areas which are affected by BV-FTD, and again we have an overlap here, as shown in yellow in this case, in the frontomedian cortex. So this is also a very important region why patients might be impaired in moral cognition. And of course, what are the consequences if you are impaired in moral cognition? You might show criminal behavior, and this is indeed the case. So in behavioral variant frontotemporal dementia, approximately 40% of the subjects show criminal behavior, like sexual advances, theft, public urination, and violence. This is an important issue because sometimes you don't know that the person changes, elderly person, and commits such criminal behavior, and you don't know why they are doing that. So this is the concept we actually developed. I cannot explain the details. I only just want to show that the frontomedian structures are the hotspot for the disease, and which is a hub which connects all these atrophy changes, hypometabolism changes, and cognitive changes in the disease. And based on these different cognitive functions, we can also reconstruct the symptoms, what they show, like loss of empathy, mind blindness, or dysexecutive syndrome, disinhibition, and apathy. Okay, so we can, with these approaches, we can reconceptualize diseases, not only BV-FTD, but also other diseases, of course. How can we translate meta-analysis into clinical routine? So this is the next point I want to discuss. How can we bring the results of the meta-analysis back to the society, how we can improve treatment? So although we increase a lot the generalizability with the meta-analysis, the important point is we lose personalization. So we lose the single patient. The higher the numbers involved in studies are, the less the single patient is reflected. And we have to go back and return to this area, to the patient. So we have used these meta-analyses, the results of the meta-analysis for BV-FTD, to optimize detection of BV-FTD. These are results for support vector machine classification to identify patients in comparison to controls, and we reach across the whole brain an accuracy of 82%. But if we go to the ROIs extracted in the meta-analysis, we can increase the accuracy, so we can utilize the meta-analysis to improve diagnosis of the patient. At the end, I want to present another patient, but in this case, it's a 50-year-old woman with bilateral stroke lesions in the so-called inferior frontal junction area. This happened in the territory of the middle cerebral artery due to atrial fibrillation, quite common disease, of course. She complained cognitive slowing, impairments in memory calculation, word finding difficulties, so a rather blurry pattern of symptoms. These are the MRI images. You can see here, these are the lesions, and they are exactly in the inferior frontal junction area, which is discussed, as I already mentioned, to be connected to executive dysfunction. We look for the neuropsychological test results. You can find the pattern here. It's rather complex, so we used a lot of different neuropsychological tests, but most important are executive functions. These are percentile ranks compared to healthy controls, and here you see a very strong impairment, especially in executive functions, which is very interesting because the inferior frontal junction is with this model, the patient as a model, you can validate that this is a good theory to think that the inferior frontal junction is explicitly related to executive dysfunction and function, of course, in healthy people. So this is like a PROCAR, like a case report like PROCAR has done or Wernicke, but we wanted to do something else. So don't be afraid that Mars attacks start now. It's just that I want to introduce another method. That's meta-analytical reading of symptoms, called Mars, where we can predict the symptoms in single patient with meta-analytical tools. So here you can see, again, the lesions of the patient, so the single patient, what I have presented before, in the left and in the right, inferior frontal junction area. This was, of course, connected with a larger network involving other regions, and these are the results for the behavioral domain profiles. So we went again back to the brain map database and extracted the cognitive functions which are associated with these brain regions, and these are the results. And what you can see here on the right side, it's Stroop test, working memory, so classical executive function tasks. And on the left side, there are a lot more tasks, but also NBAC, so again, executive function tests, but also language tests, or language paradigms which show activation in normal subjects there. And interestingly, this patient indeed did show a language impairment in the beginning, right after the stroke, but later on the language improved, the language functions, and the executive deficits remained. Okay, I want to now summarize the results of the talk, or what I've presented here. So I think that meta-analytical data mining can reveal neural networks facilitating diagnosis and differential diagnosis, that we can use it to reconceptualize neuropsychiatric diseases, that we can also use meta-analysis to support personalization in medicine if we combine it with other methods like machine learning. And on this way, from diagnosis of neurodegeneration to therapy inducing neuroregeneration, which is, of course, an ambitious, very ambitious aim, we can use a magic black prediction box, which also other talks have discussed. And in the end, I think we can predict diagnosis, differential diagnosis, symptoms, histopathology, if we additionally involve, of course, other methods like PET, amyloid PET, tau PET. We can also intend to use personalized therapy approaches, and we can also predict prognosis. Thanks a lot for your attention, and if there are any questions, please ask these questions.